Hello, my name's Alison Porter from Swansea University, and I'm going to be talking about emergency admission risk prediction tools in primary care to reduce emergency admissions to hospital, the gap between evidence and practice. So what are we talking about? Well, people like this lady here, Shirley, seen in conversation with her GP, part of a older population group, certain number of comorbidities, and potentially at risk of having to have an emergency hospital admission. Not a great thing if you can avoid it. It's not nice for the patient. It's not necessarily the most effective way of delivering healthcare. So one approach to dealing with this is to go, well, okay, if we can find the people who are at the highest risk of hospital admission, maybe we can step in and do something to reduce that risk with intelligently targeted interventions, which are going to go some way to improve care and reduce costs, avoid those emergency admissions and bed days. The best way to do that, we know, is to use tools which use algorithms based on routine data. Of course, doctors do have a pretty clear idea of patients who are at risk, but they're not actually as accurate as a predictive risk tool. And what those can do is stratify the practice population. In other words, split it up into groups of people at different levels of risk. Here's an example of one of the tools which does this. This is one that's called Prism, that was developed by and for the NHS in Wales. About 36 different bits of information feed in there about each patient, so demographic information, age and so on, but also information on diagnoses, previous healthcare use and so forth. So with information on all the patients at a practice, there's a number of different ways that a practice manager or a GP or a nurse can draw something useful from that about the risk of individual patients. And here is one of the displays you can get with the Prism tool, which is a cone there of risk. There's a very small number of people at the top level, level 4, the highest risk of admission as an emergency within the subsequent 12 months. And then bigger population groups, moderate risk, low risk, and then the vast majority of the patients of the practice are very low risk. And people can move between those levels. The tool is constantly refreshed and updated with information on patients about new diagnoses, new treatments and so forth. So once a month, for example, you could go in there and see who are the top risk patients, or potentially the next level down, the ones you may have more chance to intervene with and do something useful. So we evaluated the impact of that particular tool, the Prism tool, in a study we call Prismatic, the Predictive Risk Stratification Model, a randomised step wedge trial in primary care. So this was conducted across 32 practices in one health board area in South Wales. So the tools rolled out cluster by cluster across all those practices, which in effect means that each practice or each cluster is its own control before and after. And so that's NIHR funded study is completed now. So there's the big report in the NIHR Journals Library. There's a slightly shorter write-up of it in Quality and Safety in Healthcare. What did we find? Well, our primary outcome we were interested in was the number of emergency hospital admissions. We were also looking at things like bed days, emergency department attendances, outpatient attendances, and of course costs. What we found, what we were hoping to find, or what the people who designed the tool were hoping to see, was a reduction in those. Actually, what we found was that all of those increased. And some of the other things we collected information on about patient satisfaction, patient quality of life from standardised questionnaires, there was no change in those, no significant change. So what we saw there was something which was introduced in order to save costs and actually resulted in additional costs, £76 per patient per year. That's every patient registered in a practice within this health board area, not just the ones who had admissions or the ones at high risk groups, everybody. So you can see when you scale that up to the number of people in the area, that starts to get to be quite serious money, hundreds of thousands of pounds. Yet, these tools are in use. So we did a study called EARP, Emergency Admission Risk Prediction Survey, to explore the implementation and use of these tools across primary care in the United Kingdom. So we wanted to find out roughly how many general practices did have access to these tools, not necessarily how much they were using them, but whether they were available within the practice. We wanted to find out which tools they were and to look at how they were being used. So going to every practice would have been a vast task, as there are thousands. So we went via the sort of higher level groups. So in England, the clinical commissioning groups, in Wales, Scotland and Northern Ireland, the health boards. And then we followed up with semi-structured interviews with a sample of sites. We had an amazing response rate, 74%. And what they told us, the representatives from the health boards and clinical commissioning groups, that they indicated that overall across the UK, about 3/4 of practices have access to a tool at the time of the survey, 73.2%. There's a big variation across the UK. So Northern Ireland, 100%, Scotland, 84%, England, 75%, but then variation across England. Wales, down at 14%. Now, this is not surprising because the Welsh Government, having developed the Prism tool, held off on full implementation, awaiting results of the prismatic study. So we then asked our respondents about what different tools were being used and about how they were being used. So it's an extraordinary number of different tools were mentioned, over 39 different tools. Some of them were locally developed. Some of them were developed on a larger scale. So, for example, Scotland had an equivalent to Prism called Sparra. And some of them were commercial products from providers such as United Health that local NHS services had bought into. And of those, 64% were based on validated risk models. The most common reason cited for using them was about individual patient care. So case finding, identifying patients for follow-up or review by GP practice staff. So that was mentioned by 3/4 of the respondents. The other main uses were around sort of service planning or development. 28% at practice or practice group level. More commonly, 41% at the higher level, at CCG level or health board. And then a minority of people, 18%, mentioned the use of these tools in relation to service evaluations. If you want to know more about this, there is a paper will be coming out in British Journal of General Practice, which says a bit more. So that's the picture. We found in Wales this tool which was having the opposite effect to what we hoped, and yet still there are loads and loads of tools out there in use. And certainly in England, this is not surprising because there's been big sort of policy push towards this kind of thing. So going back to 2005, the old National Service Framework for Long-Term Conditions mentioned and promoted the use of risk stratification tools. Then there was an enhanced service specification, so GPs were contracted to identify a certain percentage of their population and put in interventions, and they were strongly encouraged to use tools to do that. That ran for a couple of years. It was discontinued in 2017, but in the meantime, quite a lot of money was spent on paying GPs to use such tools. What else? We've got within NICE guidelines, the one on multimorbidity mentions this as good practice, something to be encouraged. There was a lot of work through the Vanguards programme, sort of local developmental work in terms of primary care across England, promotion of risk stratification in that. They did not, the evaluation that was attached to that didn't find massive benefits either. And then finally, this is very recent, March 2020, the framework for enhanced health in care homes, primary care contracted to deliver additional services to care homes, and mentioned within that document is the use of risk stratification. So it's embedded in policy. Meanwhile, in Wales, as I mentioned, the Welsh Government was waiting for research evidence to inform decisions about future use. So they didn't go ahead with the full rollout of the Prism tool. And we estimate, modelling from our trial and survey findings, that this non-implementation in Wales has avoided an estimated 30,000 additional admissions to hospital, 162,000 bed days and £200 million per year. Now, of course, it's possible that those additional admissions, additional bed days were needed. It may just be that use of the tool is uncovering need that would otherwise go hidden. It's not unambiguous. But since the stated aim of the tool was to bring about reductions in those things, it's quite a significant finding. So why might there be this gap between evidence and practice, certainly what's going on in other parts of the UK? Well, firstly, I guess money's already invested. There was a lot of interest in this kind of thing before there was any research evidence to support the implementation of risk stratification tools. Maybe that people are simply waiting for more evidence, or believe that it's a complex situation, that there are, of course, many things which can influence emergency admissions, not just the specific intervention within primary care. And it's also, I think, worth thinking about the idea of technophilia, this enthusiasm for IT and healthcare, which sometimes is seen as a solution in itself, rather than helping you to get to a certain point that you need to be. So although ours is the largest study in this area to date, it's not the only one to cast doubt on the value of GP-led case management for high-risk patients. So there was an evaluation in Manchester with similar findings. It's also been suggested that an emphasis on those with the highest risk scores is not appropriate, as there may be little you can do to keep these people safe and well at home. So instead you may be better off going for that next level down, the tier 3, because you like to be able to have more impact with those at slightly lower risk. And as Professor Martin Rowland from Cambridge University said, when considering our research, perhaps the emphasis on reducing emissions and cost savings is wrong. The focus should be just on improving care. And there's another message here too, I think, about the challenges of ensuring that health policy is based on the best research evidence. So while our study was taking place, NHS England brought in 3 annual cycles of payments for case management of those at risk of admission. So would they have committed these costs if our results were known in advance? Perhaps not. But the time it takes to design, gain funding, then deliver robust research, which in the case of this study was 7 years, is at odds with a desire to achieve immediate impact on health challenges. Thanks very much for looking at this presentation. If you've got any comments or questions, please let us know by writing below the video, and we will read and respond to them. If you want to get in touch directly by email, there's my email address below. Thanks.